Hi, my name is Jennifer Moranke. I'm the Director of Endoscopy at Penn State Hershey, and I'm pleased to be here with Dr. Arvind Trindade from Long Island Jewish, where he is the Director of Endoscopy. He's going to be talking about his study, the incremental yield of dysplasia detection in Barrett's esophagus using volumetric laser endomicroscopy with and without laser marking compared with a standard random biopsy protocol. Thanks so much for being here today.
Thank you for having me. Thank you to the editors at GIE for allowing me to talk about our article in this article series, author series. I appreciate it.
Great. So what was the premise of your study?
So I'll take a step back and, for surveillance in Barrett's esophagus, it's extremely difficult to find dysplasia. As you know, it's almost like finding a needle in a haystack. And so, there's been a number of studies now by Doug Corley and Pratik Sharma, and they've shown that finding dysplasia in Barrett's esophagus can be hard to do, and sometimes we miss dysplasia and we miss cancers. And so what we do in our center at Long Island Jewish Medical Center is we actually started using volumetric laser endomicroscopy since 2014 and beyond. So from 2014 to 2016, it was volumetric laser endomicroscopy without laser marking, and then in the middle of July is when the laser marking part of it came about, and so we have good data to compare, VLE with laser marking and without. And prior to VLE, we were just mainly surveying with Seattle protocol biopsies, and then at the discretion of some physicians, they were also just using random biopsy protocol. So what we decided to do in this paper is just compare these four different groups: random biopsy, Seattle protocol biopsy, VLE without laser marking, and then VLE with laser marking.
Great. So how was your study carried out? Was it retrospective or it was prospective?
So it's a retrospective study, and we essentially went back to the prospective maintained database, Provations, as most people use, and we compared all Barrett's esophagus surveillance exams and using the different protocols that I just talked about.
So what did you find?
Yeah, so what we essentially found was that VLE with laser marking surveillance, we actually found that the incremental yield of dysplasia was high, statistically significant compared to Seattle protocol biopsy. So it was a 34% yield of dysplasia in the VLE with laser marking versus 20% with Seattle protocol biopsy. And for neoplasia, which is just high-grade dysplasia and intramucosal cancer, it was 14% with VLE with laser marking and then 1% with the Seattle protocol biopsy. And this is what we've been seeing in practice too, and so we're happy to be able to show that in the paper.
Yeah. Now, what were your subgroups in terms of patient population? Did everyone get VLE or VLE with laser versus Seattle protocol?
Yeah, so these are consecutive patients. So in the 2011 to 2014-15 group that were receiving random biopsies, we didn't have VLE, so they were just mainly random biopsy protocol. And then in the VLE groups, it was at the discretion of the endoscopist whether or not they wanted to do Seattle protocol or not. So it was about 33% of patients received the Seattle protocol biopsies in addition to the VLE protocol. And there's an AGA white paper from 2015 in CGH showing that if you have a good sensitivity and specificity with any advanced imaging, that it's okay to forego the Seattle protocol biopsies.
Great. And then in terms of the patient population for who had been previously treated for their Barrett's esophagus, assuming that they had had prior dysplasia, how did that break down? Yeah,
that's a very good question. So we did a subgroup analysis, and there's a table in the paper that shows that, and we broke down the groups by treatment naive with no known dysplasia, treatment naive with dysplasia, and then post-treatment surveillance. And what we found was with VLE with laser marking, we're able to find an incremental yield to dysplasia yield in treatment naive patients with no known dysplasia and in post-treatment surveillance. However, in the group with the known dysplasia who are treatment naive, there was no difference in dysplasia yield between VLE and Seattle protocol biopsy, and you would sort of expect that because that group was known to have dysplasia, and the reason why we did the exam is to see whether or not we could upstage the class of dysplasia.
Great. What's your perception of what kind of impact the addition of laser marking has made with the VLE technology?
Yeah. So we were early adopters of VLE, and we've been doing it without laser marking, which we thought it was pretty good. And then when we started using laser marking, we noticed that there's a huge difference. Sometimes where we think the abnormality is what we're seeing on VLE may be, and then when we see the laser marks, we're sometimes very surprised. So, so I think the laser marking has made a big difference, and our paper shows that between laser marking and without laser marking, there's an incremental yield of dysplasia.
Yeah. In terms of the time that it takes to do these studies, so the actual scan takes about 90 seconds, as you guys reported in your paper, but how long does it take to interpret the images?
Yeah, so each 6 centimeter segment takes 90 seconds to scan. And so if you have a very long segment of Barrett's, it may be longer than the 90 seconds. And as you mentioned, image interpretation could sometimes take much longer. And like anything else in any advanced imaging study, there's a learning curve. So initially, when we first started doing these exams back in 2014, it may have taken at least 45 minutes to go through everything from balloon inflation, scanning, and image interpretation. But now a routine procedure maybe takes about half an hour with the laser marking and biopsies.
Great. So compared to some other, advanced imaging technologies or other methods of tissue acquisition, namely Watts 3D, how do you think that the VLE technology compares?
So what's great about VLE is that it's wide field imaging, and there's not many other advanced imaging technologies out there that are wide field. And by wide field, I mean we're imaging 360 degrees, the whole esophagus, and then we're able to pinpoint where the abnormalities are and actually put laser marks around it and then do tissue biopsy. And so I think that's a game changer. And if prospective studies could show what we showed in this retrospective study, I think that this will be a technology that a lot of people will be using.
Yeah, so moving forward, what do you see as the role for VLE with laser?
So I think our paper is shown in academic centers, and if you have a good sensitivity and specificity that for dysplasia yield, especially compared to random biopsies, that it's appropriate to use VLE with laser marking for surveillance. And I think if further prospective studies could also show this, and it could be branched out into the community.
Great. Well, thanks so much for spending time with me today to talk about your very important study. It's been a pleasure.
It's been a pleasure.
Great.
Thank you. Thank you very much.
Sure thing.